Good morning, everyone, and welcome to our final VHHA Patient Experience webinar of the year. My name is Abraham Segrist, the Vice President for Quality and Patient Safety here at the VHHA, and we're so glad to have, quite a few of you with us this morning. We've got a fairly full agenda, so we want to hear from a couple of our colleagues around the state, but first we'll hear from our two chief nurse executives who've been faithfully leading a group of patient experience leaders throughout the year to put together a comprehensive statewide plan for shared learning. Before I turn over to them, just a couple of housekeeping notes. A copy of the handouts for today's presentation is available in the handouts section of your webinar platform. So if you go to handouts and click that, you'll be able to see and download a copy of the presentation. If you'd like to ask any of the panelists any questions, there's also a question/chat feature. You simply go there and chat your questions in, and we'll take those at the end of today's webinar. Next, when the webinar ends, there will be a 2-question survey asking for your feedback and suggestions for future work together. So we ask that you take a few minutes to complete that survey. And then finally, we will be sending out a copy of the recording and a copy of the handouts to everyone who registered for today's event. So without further ado, it is now my pleasure to turn the webinar over to Jennifer Kreiser, Vice President, Chief Nursing Officer at Centera Lee, and Brenda Woodcock, Richmond Market Chief Nursing Officer with Bon Secours Augusta Health, who have been our fearless leaders throughout this year. So Jennifer and then Brenda, I'll turn it over to you.
All right, great. So it's really been quite a year for the forum. We've developed a plan in 2022, which aligns and builds upon the 4 foundations of patient experience. These 4 foundations have been the framework for the VHHA's prior work prior to this year. So at the beginning of the year, we spent time and we surveyed both VHHA members, and we also surveyed our hospitals. And what we wanted to do there was to see what the concerns were around patient experience, to talk about post-COVID, and to see what we need to do differently in the state of Virginia to make sure that our patients are getting the quality care and service that they deserve. So at the beginning, we had our patients, for their highest priority during these surveys, it was that effective communication and being kind and having a caring staff. So for our patients, that was the highest priority. For our hospitals, the highest priorities were concerns about deterioration in communication and relationships, and then, of course, staff burnout. So realizing that that was a big concern, one of the things that we wanted to do was not add work to our already overwhelmed staff. So what we did is we came up with a plan of creating playbooks, and these included practical, action-oriented, simple guides for improvement. We also launched our first communication playbook in October, and so many of you on here may have already seen those and used several of those tools that were in there. And then recently, we restarted the VHHA data dashboard to enable our leaders to see their performance at a glance and compare that not only to hospitals within maybe their systems, but in the state of Virginia, and compared where they have been and where they are now. So originally that was something that was being used, and then it was gone for a little bit of time and recently came back. I know it's something that I use every day, so I really appreciate that. So I'm going to turn it over to the next slide.
All right, so member engagement is what makes the forum work. We all know that. And the patient experience work plan and all the activities that were completed in 2022 represent insights and ideas that were generated by many Virginia hospitals on this call today. This level of engagement is essential as we continue to be confronted with challenges that require us to be responsive and resilient, coming together as a community to find out what innovations are making a difference at the front line is really essential. Often it's the simple things that turn out to be the most impactful and powerful for our patients, families, and our teams. Today, we have 2 member organizations and 3 presenters who have stepped forward to share what is working for them on improving communication. So today we'll hear from Sam Garber and Brandon Jones, They'll be discussing Carilion Clinic's simulation-based program for nurse leader rounding. We all know that rounding is incredibly effective in improving patient experience if it's done well, but doing it well is certainly not easy. Brandon and Sam will provide invaluable guidance on how to set up your teams for success. The second presenter will be Matt Fidler from Augusta Health, who will be discussing the results of their post-discharge phone call pilot using qualitative and quantitative data. He reminds us that improving communication isn't just about HCAHPS scores, but also about the difference we make in people's lives. After hearing from our colleagues at Carilion and Augusta, we will hear from our own Ms. Carrie Brady with the VHHA team. And I want to thank our presenters today and to everyone who has contributed their thoughts and ideas in the 2022 work. Please keep sharing your ideas and innovations with us in 2023. We certainly could not do it without you. Thank you.
So Sam and Brandon, the floor is all yours.
Yeah, I got the impression that it was going to be when the slide came up. So thanks, Abraham, and thank y'all for letting us take a little bit of the time this morning to share with you. I wish I could get more credit out of this than I do, but the credit that I bear here is making a path for Brandon, clearing everything out of his way and turning him loose. This is some work that he has spent several years working in with some of the rest of our staff at Carilion Clinic, and I'm very proud of the work that he's done, and am excited for him to be able to share with you. I have been at Carilion over 25 years. I think my blood is probably partly blue, but that's okay. It's a good family, and I'm proud to be part of it, and I'm proud to have people working with me like Brandon Jones. So Brandon, I'm going to turn it over to you.
Thank you. Yeah, so very briefly, just by way of introductions, my name's Brandon. I am a nurse by trade. I've been a nurse for the last 18 years, critical care and emergency medicine background, various leadership levels, but also at the bedside. And most recently was one of our directors in our level 1 trauma center in Roanoke, which is why I have no more hair left and frequently will wear a hat, but we'll just leave it at that. And transitioned into this patient experience work full-time about 5 years ago or so. And really want to kind of talk about today this idea that we had around using simulation to help to improve our leaders' really confidence with doing rounding. So on the next slide, you're going to see kind of our burning platform here at Carilion around moments. And what we know is that for our patients, for our families, for our visitors, every single moment matters. And when we talk about these moments, it's not just moments that our caregivers are involved in, but also the moments that our leaders can help to impact as well. So next slide, you're going to see some of the objectives for our time together today. We wanted to identify, describe, examine, and then design. And then hopefully by the end of our discussion today, you'll be able to do the same thing if you feel like it fits for your organization. So next slide is kind of the history of our leader rounding at Carilion. So we initially started back in 2014 as a tactic to work towards achieving some key strategies identified by our then interim CNO. A group of leaders came together to really design a template, begin conversations with their peers around some daily patient rounding. There was an initial script created using some evidence-based practice. So everybody's very familiar, I'm sure, with the Studer Group. So some of their conversations with the organizations began to evolve. A few iterations later, we purchased actually a rounding technology and deployed it in September of 2017. We created some education to provide leaders information on how to navigate the new tool, but at this point had still not made a tremendous dent in our patients' overall experience, and then took a step back as we were able to expand resources and really support the patient experience. The simulation center leadership, coupled with our patient experience team and nursing, was really a great breeding ground to try to make an impact. So on the next slide, just very quickly, simulation at Carilion Clinic. We are very fortunate to have a dedicated simulation center. It's called the Center for Simulation Research and Patient Safety, and it's a full spectrum of high quality clinical simulation and active experiential learning for healthcare providers. It is a busy, busy place and is used by many different areas in our organization. So on the next slide, you're going to see how we kind of defined our problem. So what we knew was that our leaders were out rounding, but we weren't seeing a lot of impact. We weren't seeing the known patient experience impact that the evidence shows, right? So we went and began to do some shadowing and led to some, I think, really important insights. And what we found was that our education was really designed solely on using the tool. And what we found when we were looking at the data was that we had an increase in our quantity of rounds that were occurring. Our leaders were getting out there and they were doing all kinds of rounding. So the quantity of rounds were there, but there was a question as to the quality of the rounds that were occurring. And we looked at the quality of rounds from our patient's perception, and we looked at one specific question that we have on our survey that says, did a leader round on you daily? And what we found was when we were comparing those two things, while the quantity of rounds were increasing, the percentage of patients that were saying, yeah, a leader rounded on me every single day was not increasing at all. And as Brenda said, you know, leader rounding is a known best practice for improving patient experience. And the evidence is very, very clear. The phenomenal impact of meaningful leader rounds. And I think meaningful is the key word there, and the ability to improve our overall experience. So what we found was that we had a real big gap in preparing our leaders. Essentially, it was, hey, here's how you use the tool, but there was a huge gap in the here's how you round. Sometimes it can be very easy to say, hey, you're a leader, so you should automatically know how to round, right? Well, that's not true at all, because many times our leaders are great clinicians and we're trying to build our great leaders. So we knew that something was missing and we had to develop some education. So on the next slide, we began to sit back, and really this idea came about of, all right, leader rounding is a proven best practice. Simulation is a proven best practice. Is there a way to bring those two together? So we actually went out into the literature and tried to look and see if there was anything out there around using simulation to help to educate our nurse leaders on how to round. And there was a huge gap in the literature with these two things. So we thought that maybe we may be onto something. So we actually embarked on a little bit of a research study as we went about this project. So on the next slide, you're going to see some of the kind of the purpose of our project. And honestly, it all came back to the patient, period. Leader rounding, engaging our leaders, improving their rounding, improving their confidence in rounding, we knew would result in better patient safety, higher quality, and more compassionate connected care. So we wanted to create a more robust educational experience for our nurse leaders beyond just the tool itself. We wanted to develop that affective and psychomotor domain of learning. Those are really, really missing in what was our current education. And then we wanted to improve our nurse leader confidence in purposeful rounding. So our hypothesis was that as we improved their confidence, then their quality of rounds could also be improved. So on the next slide, you're going to see some of our first steps. We actually went through the IRB process. They determined it was QA/QI. We initially received really great executive support, which was key to our overall success. We chose our simulation modality. Now listen, I'm no expert when it comes to simulation, so we had some really strong partners in our simulation team who helped us to choose the correct simulation modality. And the simulation modality that worked for us was what they call standardized patients. So we did not use the dummies that were there. We used actual trained actors who performed as simulated patients. So we did some online pre-work. Some of that online pre-work was actually the training of the tool, and then we also had it to be required participation. So that executive support was really, really important with the required participation. So on the next slide, you're going to see how we kind of developed the course. So it was really important for us that the simulation experience be real life. So again, we had that collaboration of our 3 organizational departments: nursing, patient experience, and our simulation center. We used the standardized patient program and our partners at Virginia Tech Carilion School of Medicine. And we used feedback from experienced nurse leaders for the scenario creation. So once we created the simulation modality, we had to create the scenarios. So instead of us just kind of sitting back saying, well, I think we should make this scenario or this one, we actually went out to our nurse leaders and said, hey, tell us about some really challenging rounding experiences that you have had that maybe you wish you had had some training on, because we knew we weren't going to create scenarios where it was you round and the patient and their family says, yeah, everything's great, thank you for coming in, right? That was not our idea at all. So we went to our nurse leaders and wanted to get some actual real scenarios, and then went back to them to say, all right, here's some of our scenarios. Now, what would you do in this situation? What did you do in this situation? So these realistic scenarios were obtained from our nursing leaders and were the basis for our 6 simulation designs. You can see an example of that realistic scenario, how we developed it on the slide now. Again, it was real life situations. We used effective behaviors and responses. We set the stage for what are we expecting. And the really, really cool thing that I think was the best part about using standardized patients was they were actually trained on trigger words and trigger behaviors. So for example, in our emergency department round, we trained our standardized patients that if a leader, when they're rounding and you're talking about really long wait times, if the leader says something like, well, you know, we're a level 1 trauma center, or we just had a trauma patient come in, that was a trigger, right, for the patient, for the standardized patient to begin to escalate. So they had escalatory triggers and de-escalation triggers built in, which were part of the training for the standardized patients, which made it even more realistic. So on the next slide, you're going to see kind of that simulation process. It's a little bit of a busy slide, but basically the participants would go through, they would do some pre-work, they'd go through the pre-brief. I can tell you that if you're going to be partnering with your simulation partners, this pre-brief was vitally important, because it really helped to set the stage for the overall simulation experience. Because the pre-brief was done by our simulation team. We had a lot of leaders with anxiety, some leaders that had never done rounding before, some leaders that had never been in the sim center before. So they really helped to set those expectations. We set the expectations that you're not being graded. You know, your one-up is not going to get a report of how you did today. This is a safe space. And you can see some of those pictures there of our leaders actually doing the rounds with our standardized patients. So it was within a hospital room, of course, in our simulation center. Some of our rounds were not with the patient, but they were with the family. So you can see that on the bottom left-hand corner. And we tried to keep it to 5 minutes. The interesting thing is I told our leaders, we're not going to come over the intercom and say, okay, your round is done, your simulation is done. You need to organically finish this thing just like you would any other round. But another really cool thing was, as the leaders were rounding here, we had cameras, and all of the other leaders, so we had 6 leaders that were there at a time per session, they were actually watching the other person do their rounds. So we were doing shared learning. We were having some experiential learning as well. And then we would actually then come back and debrief. And the debriefing part was really important. Well, it was led by our simulation team, because that debriefing was, the very first question was, all right, what would you do next? But in my humble opinion, I know I've said it before a few times already, the cool thing, but the really, really cool thing was that our standardized patients came in and debriefed with us. And they actually gave us some feedback from the patient perspective about the round. So then we, as the patient experience team and the nursing team, would share some best practices with our leaders. We had like a little handout for them, but the pre-brief and the debrief were vitally important for the overall success of this project. And having our standardized patients come back in and provide feedback from the patient's perspective was invaluable. And as we looked at a lot of the feedback, and I'm going to go through a few of the feedback towards the end, some of our qualitative data from our participants, one of the most frequently mentioned items was the benefit of the standardized patients coming in and providing us with feedback. And it was overwhelmingly positive feedback. And anytime they had some feedback around maybe something that needed to be improved, it was always really constructive because they were trained actors and they do this stuff at the med school anyway. So on the next slide, you're going to see some of our quantitative feedback from our initial participants, because remember, we were doing this as a research study. 100% felt that the education succeeded in meeting the objectives. 83% felt that it was going to impact their leadership skills. 89% felt that the education was going to impact their communication skills. And then 73%, felt that it was going to impact their confidence levels. Moving forward, looking at boosting the actual leader's confidence, because that was kind of one of our hypotheses, you can see on a 5-point scale, it was 4.7, 4.8 around what they felt was some of the most beneficial things when it came to the simulation. Their confidence and rounding ability, the debriefing and group discussion was really highly rated. The actual learning environment, and the fact, we're patient experienced people, so we had to put the would recommend in there. So you can see the would recommend, they were recommending, and that was our really plea to the leaders, was other leaders may be a little bit afraid to come in here. If you had a great experience in this leadership simulation program, please go back out and share that with your other leaders and recommend that they come in and be a part of this. So on the next slide was one of probably some of the best stuff that we got, and that was some of the qualitative feedback. I did include some of the feedback from our most recent simulation that took place earlier this month. But I'm not going to sit here and read them all to you, but I think that there's some really good nuggets of information. And you can see that the comfort level, that there was no stress, very non-threatening. The fact that it was a great learning experience that taught important tools. There were a mixture of new leaders who had never rounded before and leaders who had been doing rounds before and maybe learned some things that they should change and learn some new tactics for rounding. So here's one new to rounding, great first experience, fantastic class. You can see about the conversations being very helpful in building their leader confidence. On the next slide, you're going to see some of our strategies for success. So we did struggle in the beginning getting buy-in, if you will, from the leaders. And that really took us leaning on not only our executive leaders, but the unit level leaders, leaning on their one-ups to help to not necessarily force people to come to the simulation, but to highly encourage and remind them that it is required. So the reason for that was because many times our leaders are incredibly busy, but they were also a little bit weary of coming into the simulation center and doing this type of simulation, because it's something that is not done often. Simulation is not frequently used in this way. The other opportunities and strategies for success was recognizing that leaders do overall lack confidence when they were coming into that simulation. And the pre-brief was vitally, vitally important. In that pre-brief, again, we discussed the anxieties, the known anxiety that we're going to have when we're doing simulation. But the cool thing was our simulation team was able to explore strategies for success and really provide detailed expectations. The various practice settings for leaders, what we knew was that one simulation scenario was not going to be kind of a cookie cutter, one size fits all. The standardized patients were vital in helping to adapt different elements of scenarios. So we had NICU, we had PICU, we had the operating room, we had emergency department, and then we had inpatient. But even within inpatient, there were different practice settings that our standardized patients were really great about adapting different elements to. And then we did have to use, again, some pretty direct communication strategies, which included daily enrollment updates to one-ups of the leaders and specific detailed email communications to our targeted participants to try to get buy-in. I'd like to say that now at this point, we have really, really good buy-in. We've been doing this now. Our very first simulation session actually started before COVID. We were, of course, on pause for a while during COVID, but we've been able to ramp this back up over the last about 6 to 8 months. And we have really, really great buy-in. Actually, we have leaders now that are emailing us saying, hey, when's the next class? I really, really want to get into this class. So on the next slide, you're going to see kind of where do we go from here. We continue to look and review our data around the patient's perception of rounds that are occurring. We are looking to see the possibility of actually beginning to connect some data, so our rounding data and our patient experience data, looking at that at the individual patient level, so that if there is a leader who says, yeah, I rounded on this patient every single day, but then we look at that individual patient's feedback in our patient experience survey, and that patient says, no, I didn't receive a round, then there's a disconnect there that we need to explore. So we're beginning to look at some opportunities to break down silos within the data. We're adding to our knowledge base of leader rounding, so we're continuing to expand our bank of simulation scenarios. Our leaders that have gone through the rounding have actually provided us with some pretty cool ideas around scenarios, so we're taking some of those into consideration, varying our specialty scenarios. So again, even within our inpatient space, there's a lot of specialties, so beginning to try to really tailor our scenarios to the different specialties. Sustainability is one of the things that we were really purposeful about, and ensuring that we can continue this process not only with our simulation team, but also with our standardized patients and continued buy-in from nursing was really important. And we've gotten that buy-in from our chief nursing officer, our other VPs that have some leadership responsibilities over nursing. And then we've actually looked at other rounding simulation programs. So we do environmental service and unit director dyad rounding, where they go in and round together. So we actually did a simulation program with those two folks, and it was the first time of utilizing EVS in there. We've got some interest from our dining and nutrition services team that does rounding as well. Some of our patient representatives, specifically in the emergency department, and really specifically in some of our community sites that may not have as much experience. And then looking at executive rounding as well, because our executives are leaders. Their rounding may look a little bit different than the unit level leader rounding, and it should look different. So empowering our executives with the ability and the confidence to be able to go in and do that rounding as well. And there's a QR code about that will link you to our publication in the Journal of Nursing Administration that has a lot more details that I could provide in this very brief webinar. I think that's about all that I have. Thank you all very much.
Hey, Brandon, this is Jennifer Kreiser. I just have a question. Are your the people that are doing these simulations, are you like train the trainer and have other leaders do it, or is there a specific team that's doing it to keep it consistent?
Yeah, so there's a consistent team right now that is working on it to keep it consistent, and that is myself, one of our partners in the nursing team, and then one of our partners in the simulation team. So we have kept it pretty consistent over the last couple of years, just so that we could make sure that there was not a huge amount of variation in the information that our leaders are getting, especially in the early parts.
Well, I'm stealing the idea. I love it.
Yeah, happy to connect with anybody. Our contact information's on that very last slide, and answer any questions or go into even more detail. It's been really beneficial for us.
Great.
All right, thank y'all.
Thank you all.
Thank you all very much. So as we transition to our next presenter, as fate would have it, we can't get his camera to work. However, he has shared a couple of pictures that he's asked that we share so people can at least get a sense of who will be talking. So can you guys see Brandon there? I'm sorry. Matt, can you guys see Matt there? Can you see him, Jennifer?
I like how that's the one you picked.
Excellent. So,
very still. Yep.
I feel bad. I can't see any of you, but the trade-off is you can't see me. That was my submission to the ugly sweater contest. Yes, it does say Meowie Christmas. Yes, my 7-year-old did help me pick it out. So I figured, hey, I gotta take my licks where I can. You guys can't see me. You get some fun pictures, right? And that's to take some heat off the fact we are going to be talking about advanced analytics at 10:30 in the morning. That's me and our Santa that rounds with me during the holiday season, our patient advocate Harold, and my coordinator Shelly. We do try to keep it fun around here.
Excellent, excellent. Thanks very much for sharing. So we'll turn it over to you now, Matt. All
right, yeah, just jump into the next slide. I know math is probably not what everyone wants to talk about at 10:30 in the morning, but I will try to keep it light. So I know all of us have racked our brains throughout COVID, prior to COVID, post-COVID, no matter what, on how to improve patient satisfaction. And Post-discharge phone calls are a tactic that myself and Crystal Farmer, our CNO here at the hospital, we had kicked around for a while, but the opportunity to launch a program never really came up, because you always ask your question, you pay for it, are you going to get a return on your investment? And we just never really connected with anyone that they saw it work, right? And then all of a sudden in December, Abraham reaches out to myself, Mary, and Crystal and says, hey, I got this really good idea. We want to do a pilot program, and we want you all to participate. And it's like the light in the tunnel, the silver lining around the clouds and everything. And it's like, wow, here's our opportunity to kick something off and see if it makes a difference with minimal investment. You get to test out the Lamborghini before you buy it, right? So the vendor we used was Premedics. They were a really good partner throughout the entire project. Implementation was relatively short. I don't know if all of you have worked with vendors before, but typically they'll give you a 3-month start. And Premedics they were on the ball. They got everything going. We were done by the end of February, and we launched promptly on March 1st. Throughout the measurement period, and we did a full 2 quarters. So we started in March, but we ended in end of September. They did 4,330 patients attempted to reach out to. They attempted 8,565 calls. They actually ended up connecting with 2,529 of our patients, which is an adjusted contact rate of 64.6%, which was a lot higher than I thought, just given the population that we have here in the Shenandoah Valley. We already utilize phone-based surveys, and my big concern going into this is this too much? Nobody likes to be bothered at home. I feel like we call them a lot anyways. I wasn't sure how our patients were gonna take it. But let's move on to the next slide. Because this is how I make sense of data. I have to put it into a dashboard. I have to see things for before and after. So Q1, before we had launched anything, our overall rating of hospital was sitting at top box of 74.56%. Nursing communication was 81.41, doctor communication 84.89, responsiveness, I know all of us struggle with this one, 68.06, medication communication 68.02, environment was at 68.4, discharge communication 91.92, and care transitions 56.19. That's where we were. The effects of post-discharge phone calls were felt immediate, not just in the numbers, but in rounding with patients. They saw this as an opportunity to connect with us a little bit more post-discharge. We hope that everything's going to work out for them when they leave here, that they leave here a little bit healthier than they were when they came in. But often we don't know that. They leave us and we hope for the best, right? So anecdotally, I could tell things were going well, but still I was crossing my fingers to just, hopefully everything was going to work out in the end, and this was going to be a good pilot. So throughout Q2 and 3, we saw an overall gain of 2.36%, just about 10 percentile ranks, increase in our overall rating. Nursing communication came up 28 percentile ranks. Doctor communication came up 8. Every single domain, except for environment, that stayed relatively the same, which is to be expected. I mean, the post-discharge phone call really does focus on making sure patients have everything that they need to succeed at home. So we knew that our communication scores were going to come up, and we know that nursing and physician communication are heavily tied to our overall rating. But I was pleasantly not surprised, but I was pleased to see that every single one of the domains came up. Now, a bad statistician would stop right there and say, well, we did something different and we saw an increase, case closed, it works, and you don't need to do anything else, just do that. But that is not fair, right? Because we all do, that's not the only thing we do. And I imagine in your organizations, you see the same thing. You're not just working on one tactic, you're working on 10. So I needed to know, well, how much of an influence did this have on our overall scores? What else could have contributed to that increase? So like many of you, we also track nurse leader rounding. We want to know from our patient's perspective, did you get around with the leader while you were here? So showing for Q1, 88.5% of our patients said that they were rounded on by a nurse leader. Of course, we didn't have any Q1 totals for did you receive a post-discharge phone call, which is another question we had added throughout the pilot program, so we can do some interesting crosstabs. For Q2 and 3, 74.7% of patients shared that they got a post-discharge phone call, which is actually higher than our adjusted contact rate, but some of that goes into our ACO actually makes post-discharge phone calls on some of our more complex patients. So those numbers get kind of shuffled into the overall. But did a nurse leader round on you went from 88.5% to 92.3% between the two periods. So for a year to date, 91% of our patients say that they get a nurse leader round. We know nurse leader rounding is so impactful with patient experience in general. We know when we get our leaders to the bedside, everything improves, right? But to actually do the crosstab, we'll move on to the next slide. Once again, this is how I make sense of things. It's not enough just to see an increase. I want to know like how much influence did one thing have over another. So you can see there on the left for received discharge phone call, the split between patients that said, yes, I received one, or no, I did not, and the difference between the two. And so you can see the two populations respond differently, right? If you said yes, you for rate hospital, you respond 6% higher. For overall nursing communication, 5.97%. The lowest increase you get was environment, but once again, you can understand that, right? I'm not expecting a post-discharge phone call to improve the quietness of our hospital, right? But the highest was responsiveness, right? So there's an overall skew of 9.94% towards the positive if they received a post-discharge phone call, which is fantastic. But also knowing that we did a lot more nurse leader rounds in Q2 and Q3, to do it justice, I mean, we also have to cross-tab that. And you can see the difference is a lot more glaring between those that say, yes, I received a post or a nurse leader round, and those that said no. The minimal increase came from discharge communication, came up 15%, a little over 15%. And then the highest ends up being nursing communication, comes up 29.87% between the two populations. So you might look at this and say, all right, but what are you saying? Are you saying post-discharge phone calls don't have an impact? No, it absolutely does. It's looking at, well, where does that impact come from? Where are you really pushing things? I ran the correlation on these, and for anyone that knows anything about correlation runs from -1 to +1, and the closer you get to 0 or null, the weaker the influence between two objects. The closer you get to 1, the stronger the positive correlation is. So for these two, honestly, if I got a correlation of 0.46, I'd say, hey, we have a correlation here. Getting one of 0.81 and 0.97, I say, man, these two things are related to one another. Post-discharge phone calls and nurse leader roundings both had a significant influence over our patient experience as a whole. It's just the influence is different, right? What I noticed that post-discharge phone calls didn't, I mean, it still moved the needle in all of these domains, but I saw the greatest influence in it convinced more people that otherwise would give us 9s and 10s to actually fill out the survey, because one of the last things they mention on these phone calls is that push, right? You might receive another phone call from our vendor partner PRC, and this is how we improve things around the hospital. Really great if you filled out that survey. There's a lot of people out there that would give you 9s and 10s that just don't feel like their voice is really heard, or feel like it takes too much energy to fill out a survey, and they just don't do it. But that one extra push is enough. I mean, we got 300 more responses in those quarters, which is fantastic. That's enough to push the needle. So yeah, they might not have the biggest influence over these domains, not like nurse leader rounding does, but their influence is still felt. And it's one reason why we continue to do post-discharge phone calls, because I believe in it. Not only just because, you know, I get more survey responses in the end, but it does help push the needle in all of these domains. We're still going to do nurse leader rounding. That's never going to go away. We know what profound impact it has. But I think there's room in the arena for both, right? But aside from data, I want to show you one more thing. These are just the end results. You know, overall gain of 2.36%. Greatest increase we saw in nursing communication. Crosstab report. I mean, if you ever just want to know how two things are intrinsically related, pull a crosstab report between them. Whether you have NRC, PRC, or Press Ganey, these are all reports you can pull or have your vendor partner pull for you. And you get a better sense on how the population responds given the relationship between these two different things, right? But what I want to talk about the most is, if you'll move on to the next one, these are the things that get me. And these are the things you're never going to be able to capture on a survey. I like looking at comment reports, but even then, you're not going to ever get the full picture. We actually had a patient that had to stay on our surgical unit, and they received a post-discharge phone call. And during this phone call, they shared that their wound was feeling hot and that they had a fever. Of course, this raised a red flag with the operator that was conducting the post-discharge phone call. And they encouraged the patient to talk to their physician, to go to the ED. And the patient had shared, I really don't want to. I just got home from the hospital. I'm just going to take some medicine and I'm going to be fine. They raised it up to us. They escalated it. I got one of our nurse leaders on the phone with them and walked them through exactly what they were experiencing. And in the end, he ended up coming into our ED and hopefully stopped an infection before it really got before it got bad. And that's anecdotal. That's something that, man, when I presented all of this data, I got more oohs and ahs over an anecdotal than I ever did with math, just because you brought the human back to it, right? You showed an instance where this one process was able to possibly save a readmission or save someone losing a leg, right? Patients often share difficulties affording discharge medication, and this is not unique to us. This is felt everywhere. We often don't know about it. Whether it's a patient that is embarrassed that they can't afford their post-discharge medication, or maybe they don't know the full cost of it before they get there. And this isn't a 1 or 2 times thing. This is, you know, every week I'll get 2 or 3 of these comments from patients saying, I discharged and I went to go pick them up, and I kind of picked and choose what I got because, man, that's a lot of money. And that got to me, just because we hope that they do well, right? I already said that before. I hope when they leave here, they're a little bit healthier than they were when they came in. But man, that didn't feel good that they left here and maybe they neglected to get the one medication they really did need just because it was expensive. And thankfully, we have a really responsive ACO and a really good medication assistance program. And we were able to get those patients connected because of discharge phone calls to the ACO, get them connected to medication assistance and get them that medication. And the patients would say, like, I knew that you had something, but, you know, there's other people that need it more than me. And that's kind of not a fair statement, right? If you ever discharge and you have to kind of pick and choose what you get because you just can't afford it, that means it is for you. You know, you don't have to be at the very bottom to get assistance. Assistance is there for everybody when they need it. That's why we have these systems. That was a big one. Another case that had come up pretty frequently is patients sharing transportation concerns getting to their follow-up visit. This is big. You know, we're worried that we don't find an appointment that's convenient for them. But often we're not told that something's inconvenient. This is where we get no-shows, right? Once again, it's not a problem that is unique to us. But this is only going to get better when we start being open and honest from a patient's perspective on, what's convenient, what's not convenient. Just being able to say, listen, I can't make it to that appointment because I don't have a ride and I have no way of getting there. But once we learned about this, once again, we're able to get them connected to resources in their community, whether it's just transportation or we move them to a clinic that's a lot closer to them or a clinic that has access to public transit, anything. And what we hear back from the patients is, you're so helpful. I didn't expect you to bend over backwards to make it convenient for me for healthcare. And that comment doesn't feel good, right? Once again, not something that's unique to us, but it does highlight something, right? Something that we all kind of need to focus on. How do we make healthcare convenient for our patients? How do we make sure that they know that there are things available to them where they can get the help that they need? And aside from that, I can't tell you how many heartwarming stories I get from pre-medics. And maybe it's that a lot of their partners don't take the time to go through some of the positive comments and they use them more for the escalations. But I'm telling you, it doesn't matter how bad of a day I have. If I want to feel good, I'm either going to round for a little bit so patients will tell me what a fantastic job we're doing, or I'm just going to read some comments and send them on to the units that they need to get to. I don't think we do a good job of that. I don't think we do a good job of talking about the positive. When you see a negative, it's something that you can fix. Man, that positive will make a room feel good. I don't start a patient experience meeting. I don't start key leadership without sharing a patient story because you got to bring the human back. I could talk about math for an hour. It doesn't mean anyone's going to get anything out of it. But as soon as I share a patient story and bring them back to the reason why we do all of this, that's where you see the impact. That's where you see the oohs and ahs. That's when you see the smiles, right? So in closing, was this a worthwhile pilot? Absolutely. It gave us an experience with a tool that we'd always wanted to use. We knew it was going to have at least a small impact on our overall patient satisfaction. But from the human standpoint, it's just the right thing to do. It gives our patients one more touch point with our organization. We're a community hospital. We're there for them. I want to think that they do really well when they leave here, but this gives that one additional safety net to make sure that we don't let anything fall through the cracks, because patients they will fall through the cracks if we let them. So happy to answer any questions, or if you want to make fun of me for wearing a Meowie Christmas sweater, now is your time. I have pretty thick skin. It comes from being a therapist.
Those were great pictures, Matt. We appreciate you sharing them. Jennifer and Brenda, I see just a couple of questions in the question pod. One came, I think it was probably for Brandon and Sam. Someone was asking the cost to develop the plan and cost of training. Brandon and Sam, I don't know if you want to share that now. I know that you have your contact information in the slide, and would you prefer that the person maybe reach out to you directly to get more information about costs? Are you guys still there? Or maybe you're muted. I would recommend that the individual, Sam, any comments on that now? Would you want them to reach out to you directly?
Yeah, I'd say, sorry, Sam, I was muted. I was just talking away. Sorry about that. So yeah, I would say if you want to reach out, we did some cost sharing among the different teams. From a cost perspective, it was really the major cost was certainly the hours, the workforce of the leaders. There was a cost around the standardized patients because they came from our medical school, but yeah, happy to explore that in more detail.
Excellent. And then someone was asking, Matt, can you elaborate on your correlation calculation on page 29? Did you correlate nurse rounding scores to each domain scores over time? And I don't recall whether you answered that specific question in your presentation or not.
Absolutely. So anytime you're dealing with correlation, the more data points you have, the better. So I ended up breaking out by the week. That is that's the aggregate between all of them. So the overall correlation between all of the domains combined over the course of, and if you break it up by the week, you get more data points. More data points means you can get a more reliable correlation number when you run it. But if you ever just want to see like the math behind it or anything, if you email me, I can always share my my Excel sheets.
Abraham, I just wanted to make a quick comment about both presentations. I felt like they were both exceptional, and what I love the most is they really highlighted interventions and strategy, but more importantly, I kept hearing over and over in both of their presentations is just the caring and compassionate connection with our patients. And that's what I really love the most, and that really came through today. So thank all the speakers and presenters today. They did an amazing job, so thank you.
Excellent, excellent. Yeah, I agree. Those guys really knocked it out of the park this morning. So thank you all, our colleagues at Carilion and Augusta. And we're going to have our colleague Carrie Brady take us home. So Carrie, how do we want to wrap things up?
Okay, so you guys are a very tough act to follow, but I will just give you a little highlight as to next year. First, we wanted to just very briefly summarize Virginia's current HCAHPS data and to let you know that compared to national, you can see over there on the right side of the slide, the United States trend in almost all domains has been to go down. So we are seeing, because this is the year of data, so this data represents calendar year 2021, so it's almost a year old, the current data. But you can see Virginia held its own in almost all of the areas in two, rating, overall rating, and willingness to recommend. It's gone down by 1, consistent with national, but in the rest of the areas has held its own. There is opportunities, or there are always opportunities to improve, but we at least wanted to give that little bit of comparison for how Virginia is doing as a state. We also, and we know this is review for some of you, wanted to remind everyone that we do have the playbook. If you have not yet looked at the playbook, do not worry, this is not a huge tome based on feedback that we received. It is very simple, very straightforward. If you want to go to the next one, there are plays for each of the foundations. We have a link here to the playbook webinar in case you missed it. It is also broken down because we have the expertise of our forum telling us break it down into sections you can play with your staff. So they're 5-minute little sections, or you can play the whole webinar straight through. But if you choose to implement one of these plays, they're not resource intensive. It's a very simple but effective resource. And then if you go to the next one, just for those of you who haven't seen it, these are the kinds of things specifically to rounding questions. How do you ask, what do you ask your patient and family advisors about characteristics of effective communication and so on. So these are things that are not time consuming, not hugely overwhelming new initiative or burdensome. They're meant to be very practical, and we've gotten some great feedback. Now, in terms of planning for next year, we absolutely would love to learn from you, and we want to have playbook coaching sheets for each of the plays in the playbook because we know some of you have implemented things. Also, you may have been doing similar things and have ideas for how to do it well, just like we heard today about the huge difference it makes when you round meaningfully, for example, or do meaningful discharge phone calls versus when they're by rote and checklist oriented. So we're going to be reaching out to some organizations, and we would love to talk to you if you want to put in chat and let us know that you have some tips that you want to share. We will call you and talk to you and make it easy for us to gather that information. So we're going to be doing that early in 2023. We're also going to release a Beyond the Basics HCAHPS playbook. So the idea behind that is we have heard from members that you have a lot of new staff who may not even understand where this has come from. And HCAHPS, the way I think of HCAHPS, it's kind of like a CBC. You always run a CBC when somebody comes in, but it's an initial kind of gross diagnostic tool that then helps you combine with other information. So part of what we're going to put in this Beyond the Basics HCAHPS playbook is to show you how HCAHPS can be an initial kind of diagnostic that guides you in a direction, but then it's all of these other things that you have, including your qualitative information, that's going to help you improve. So we're going to talk about that in the Beyond the Basics HCAHPS playbook. And in February, we'll be doing a presentation about how do you make sense of what HCAHPS, patient experience, quality, and safety, how does it all fit together in a way that will make sense for your staff and align everything, because many organizations still have a lot of staff members who just don't understand why this is meaningful at all, and how does it connect to their more important goals of delivering excellent patient care. And one of the things that struck me, I'll echo what Brenda said in terms of the real commitment to engaging patient and family voices in the work that we've heard about today from our fabulous presenters, was also the focus on multiple different ways of learning, because some people are motivated by the data, some people are motivated by the stories, some people learn more experientially. There's a lot of different ways for your team to learn, and when we're respectful about engaging people on all those different levels and combining both your staff's perspective and, like we saw with the simulation, just because leaders are excellent leaders in other ways doesn't mean they know how to round. So being respectful of the fact that they needed some additional opportunities to practice and gain skills, combining that with the feedback that then you get directly from the patients about what's working, what's not working, and then learning, like, people get frustrated when patients at discharge undo all the great work you've done, but it may be a transportation issue, as we just heard. It may be something fairly simple and straightforward that we could help somebody resolve that would help make sure that the great work that's being done to preserve people's health or restore people's health sticks. So I love working with you guys. I think Virginia is top notch in terms of the collaboration that happens in this state. I've had the occasion to work with hospital associations and hospitals around the country, and Virginia is absolutely one of my favorite places to work because you are all so willing to share your expertise and to work together collaboratively for the good of your communities and of your staff, and to really just come together and create these amazing resources and share all of your ideas. So it's such a delight to be part of this team, and I am looking forward to 2023.
Excellent. So Brenda and Jennifer, we thank you both for your leadership this year, and we'll turn it back to you guys for any final comments.
Yeah, so we have we're 1 minute till the end, so I think Brenda and I just want to say thank you to our presenters today, and then thank you for everyone who's contributed this year to our patient experience journey. It really has been a collaborative effort, and we hope that you guys are seeing some benefits of the work and trying to make your lives easier as we continue to improve the patient experience across Virginia. So that's it.
Happy holidays, everyone.
Thanks, everyone.
Thank you.
Bye-bye.